I'm very happy and honored to be here today. The topic I've been assigned to speak on is patient selection for biofeedback in the conservative management of constipation. I'm Ugo Grossi and I'm a colorectal surgeon working in Treviso, University of Padua. I have nothing to declare. So let's start with the definition of biofeedback. It's quite complex. It's a conditioning treatment where information about a physiological process is converted to a simple signal to enable the patient to learn to control the disordered function. In other words, biofeedback is a mind-body technique by which we teach patients to change their physiology, to improve their mental, physical, emotional health. However, anyone who deals with pelvic floor disorders knows that the underlying pathophysiology is very complex. So the surgical sheep, after clashing with a poorly investigated patient with a rectocele or internal rectal prolapse, may sink if we don't consider a number of occult associated dysfunctions. And these data were well supported by a recent review of more than 800 defecographies, in which we showed that apart from some gender differences in the prevalence of functional and anatomical structural disorders, which frequently coexist, 1 in 5 males and 1 in 6 females may also have a completely normal exam, despite having symptoms of moderate or severe constipation, suggesting further unexplored underlying pathophysiological mechanisms. So the treatment of biofeedback for constipation dates back in 1987, where in a paper published by Netherlands authors who concluded that it was still too early to say which patients are suitable for biofeedback treatment. But what happened over the last 35 years? So in this Cochrane review published in 2014, efficacy data from 17 eligible randomized controlled trials were provided, including more than 900 participants. However, 16 trials were at high risk of bias, with heterogeneity in inclusion criteria, choice of outcome measure and comparator, and most trials had small sample sizes. Hence, the authors admitted insufficient evidence to allow any firm conclusions regarding the efficacy and safety of biofeedback for the management of chronic constipation, and the need for well-designed RCT with adequate sample sizes, validated outcome measures, and long-term follow-up. Since then, at least 3 more randomized controlled trials have been published. However, they were burdened by inadequate blinding and risk of confounding bias. So, should biofeedback be considered really the miracle cure? This knowledge gap was sought to be addressed in an NIHR-funded program, a very ambitious project launched a few years ago in UK, exploring non-drug therapies for the management of chronic constipation. This project consisted of 3 randomized controlled trials. The first, assessing a comparison between patients referred for biofeedback versus habit training, standard habit training. The second, exploring differences between high versus low volume irrigation. And the third, exploring the efficacy of laparoscopic ventral mesh rectopexy for internal rectal prolapse. But let's concentrate on study 1, which well fits this topic. Primary objectives were to determine whether pelvic floor retraining using biofeedback was more clinically effective than standardized nurse-led habit training. So, as you can see in the flowchart, patients were randomized using a 3:3:2 ratio between receiving biofeedback or habit training only, or sent for a number of anorectal physiology tests, namely INVEST. And based on the results of those tests, patients exhibiting features of a functional defecation disorder received biofeedback, the rest received habit training only. Primary clinical outcome was established at 6 months based on at least 0.4 point reduction in PAC-COL score. So here we come to the results. Habit training and biofeedback, 68 patients, the same number randomized to habit training only, and 46 patients randomized to receive anorectal physiology tests. So, as you can see in this table, in all groups, we noticed a good reduction in PACL score, and the magnitude of these changes were at least 0.8 points, far higher than the minimum important difference of 0.4 established by design. However, when you look at the comparison between habit training plus biofeedback versus habit training only, treatment difference was small and did not reach any statistical difference. Despite not reaching statistical difference, the comparison between patients undergoing investigations versus those who did not, if you look at the 95% confidence interval, the upper limit of 0.55 was above the minimum important difference of 0.4, suggesting a trend towards a benefit of patients referred for biofeedback in case of a functional defecation disorder. So the results of these trials suggested that standardized habit training was the dominant strategy with lower cost, greater quality of life at a willingness to pay of £30,000 per collie. The major caveat of this trial was under-recruitment, who inevitably underpowered the quantitative results. And we dealt with a hard-to-treat population. As you can see in a moment, the definition of a functional defecation disorder is evolving. However, the strand where that this was the largest RCT to date, where biofeedback is one of the trialed interventions for constipation, using a solid design, using reliable PROM. If we look at a patient referred for habit training only, who would benefit the most? This question was explored in a recently published study in the US, exploring the utility of anorectal testing to predict outcomes with pelvic floor physical therapy. So the group enrolled 60 treatment-naive patients with ROM for functional constipation, failing 2 weeks of soluble fiber supplementation and osmotic laxatives, who underwent anorectal manometry and balloon expulsion test, followed by community-based pelvic floor physical therapy. The outcomes were assessed at baseline and 12 weeks, with the primary endpoint being clinical response based on the PACSIM tool. Surprisingly, this inertia on our anorectal manometry and balloon expulsion test did not inform clinical outcomes, with an area under the curve below 0.6. The best predictors of success were instead the maximum squeeze pressures on 3 attempts above 192 millimeters of mercury and maintaining at least 50% of the maximum squeeze for less than 20 seconds. So what about the indication for biofeedback? In a recently Delphi exercise, who led to the publication of the ESNM guidelines on functional constipation in adults, the majority considered biofeedback as the preferred treatment for constipation due to a functional defecation disorder, whenever dedicated expertise is available, regardless of abnormal bowel transit, with a moderate level of evidence and strong recommendation. But what we mean with functional defecation disorder? According to the ROM4 criteria, a patient must fulfill criteria for IBS-C or FC, but also demonstrate features of impaired rectal evacuation based on at least 2 out of 3 anorectal physiology tests, namely balloon expulsion test, manometry, or electromyography and defecography. In a nice paper published by the Royal London Group a few years ago, in 2016, exploring the agreement between these tests, the authors considered 100 consecutive patients undergoing 4 tests of evacuatory function, including anorectal manometry, balloon expulsion using a 50 ml water filled or filled to a desired volume balloon, and evacuation proctography. Tests were considered abnormal based on published normative datasets. Surprisingly, the overall frequency of abnormal test results varied largely between groups, passing from 2/3 of patients using only anorectal manometry to slightly above 1/3 using evacuation proctography. and the agreement between tests was quite poor. However, very recently, the Mayo Clinic group reattempted to assess the agreement between these tests using slightly different measurements. They analyzed 158 patients with constipation as compared to 52 healthy subjects and considered abnormal any parameters falling below the 10th or above the 19th percentile. They basically, if you look at the left bottom boxes, when the test, anorectal manometry and balloon expulsion test, were both normal, only 14% of patients exhibited incomplete evacuation on defecography. This percentage increases to 47 or 41%, where one test was abnormal, and hit 75% of patients with incomplete evacuation in case of both abnormal tests. Why these results seems to be at odds with previous reports? As anticipated before, the authors used slightly different parameters, especially using anorectal manometry. So they concentrated on the rectoanal pressure gradient. So here we come to the conclusion. Standardized habit training is more cost-effective than biofeedback in constipated patients. Using anorectal manometry to evaluate squeeze profiles rather than dyssynergia appears useful to screen patients with chronic constipation for upfront pelvic floor physical therapy based on the likelihood of response. Compared to traditional high-resolution anorectal manometry features of dyssynergia, being inadequate increase in rectal pressure or failed anal relaxation, the rectoanal pressure gradient can better predict defecation disorder in non-responder to physical therapy, and pursuing biofeedback with such patients may be reasonable. Efforts are needed to validate and standardize biofeedback protocols across centers. And I thank you very much for your attention.